The shoulder pathway was set up to assist GPs with diagnosis, avoid unnecessary referrals to secondary care, and ensure that patients were seen by the right person at the right time. This ensures that all patients with certain pathologies follow the same care pathway. This helps GPs in decision making around when a patient may need an X-ray or be appropriate for an injection. The patient presents to their GP. Red flags need to be excluded. Calcific bursitis then needs to be excluded. These patients present with acute, severe pain on palpation beneath the acromion. It's best to advise the patient to apply heat or cold to the area. It's then advisable to treat with non-steroidal anti-inflammatories or a steroid injection. Patients may have up to 2 steroid injections at least 2 weeks apart. If there's no improvement after 3 months, consider an X-ray and refer to trauma and orthopaedics. The red flags for the shoulder consist of the following. Recent fracture or dislocation, where there have been a recent history of trauma, unusual deformity, swelling or joint diffusion. Infection, where symptoms may be suggestive of septic arthritis, for example fever or chills and hot and swollen joints. These would both be referred to A&E. Malignancy, where there may be a previous history of cancer or suspected malignancy and unexplained deformity, lymphadenopathy, weight loss and night pain. With these patients, you would need to consider investigations and referral into the 2-week wait pathway, if appropriate. Neurological lesions or cervical pathology, where the patient may present with unexplained wasting, significant sensory or motor deficits, neurovascular compromise, and pain associated with neck movements. Depending on the severity, refer to physiotherapy, neurology, or A&E if a suspected stroke. And finally, polymyalgia rheumatica. These patients are likely to be aged over 50 years and have had symptoms for over 2 weeks. It's likely to be bilateral shoulder and or pelvic girdle aching and morning stiffness lasting over 45 minutes. These patients may be treated in primary care or referred to rheumatology. Once we've excluded red flags and calcific bursitis, what about the other patients who present with shoulder pain? Firstly, we can consider those who have significantly reduced rotation. And then if rotation is full, we'd look at resisted abduction to see if this is weak or painful. You may refer to our assessment video for more detail on this. An X-ray should be ordered, an AP and axillary view, to eliminate dislocation and differentiate glenohumeral osteoarthritis from a frozen shoulder. It's important to be aware that patients can present like a frozen shoulder, but in fact have a chronically dislocated shoulder. If a patient has got a chronically dislocated shoulder on X-ray, they need to be referred straight to A&E. Those with glenohumeral joint osteoarthritis or a frozen shoulder should be referred to physiotherapy. Please see the section under Shoulders on Pathologies for more information on this. For those patients who have weak and painful abduction on assessment, we would suspect impingement or cuff pathology. If there's a history of trauma, refer to trauma and orthopaedics. Avoid advising about slings. You could try the use of non-steroidal anti-inflammatories or a steroid injection. 2 steroid injections must be used at least 6 weeks apart. Also, refer on to physiotherapy and we will manage the patient with cuff rehabilitation. Please see the section on shoulder pathologies for more detail on this. The patients who do not have reduced rotation or painful abduction fall into 3 groups: biceps tendinitis, acromioclavicular joint arthritis, or instability. Biceps tendinitis would have anterior shoulder tenderness corresponding with a long head of biceps. Acromioclavicular joint arthritis will have pain on palpation of the acromioclavicular joint and or cross-body adduction. Once a diagnosis has been made of biceps tendinitis or acromioclavicular arthritis, both pathologies would benefit for the use of non-steroidal anti-inflammatories and possibly a steroid injection. 2 injections at least 6 weeks apart. Also, refer to physiotherapy for further management. For the patient group with instability, if there was no trauma, then refer to physiotherapy and we can manage them through a programme of postural and stability exercises. If there is a history of trauma, they need to be sent to A&E. If you are unsure of the diagnosis, as long as any red flags have been excluded, simply refer to physiotherapy. All patients will be seen by us within 20 working days and will keep you informed of your patient's progress and diagnosis. Patients being referred to physiotherapy will receive a thorough assessment with a specialist musculoskeletal physiotherapist who will aim to get an accurate diagnosis of the patient's complaint. They will discuss the diagnosis with the patient and decide on an individual management plan. This may be individual sessions or our group education and rehabilitation classes for those patients presenting with instability or impingement. If a patient is failing to progress after 3 months of conservative management, our physiotherapists will refer on to secondary care for an orthopaedic opinion. To measure success of this service, all patients complete an EQ5D questionnaire and Oxford Shoulder Score at their initial appointment and on discharge. We also have specific patient satisfaction surveys for all patients on the shoulder pathway.